So, Dr. Saab, thanks for being able to answer some of these questions. One of the interesting things that especially in neuroendocrine tumors, as we go through new treatments like alpha emitters, radioligand therapy, and new approvals, how do you go about considering access to different treatments and recognizing the real-world challenges of treating oncology patients? How do you think about sequencing treatments for neuroendocrine tumors?
Yeah, the good news is that we have now a lot more options in a disease that we know patients do well, live long, so we have the luxury of actually thinking about sequencing a number of therapies. So this disease, for many patients, does not require treatment or immediate treatment. At some point, most patients will require some level of treatment. So the way we prioritize today is with lutathera, with PRRT, is one of the considerations when patients become symptomatic. It's one of the first considerations when patient becomes symptomatic because of the level of response. And for those patients, essentially, they have to be somatostatin receptor positive, so PET identifies those patients, and then they move to lutathera. So those are your symptomatic patients. And typically you treat, you go with 4 treatments, but we've rechallenged patients up to 8 to even 12 treatments in our practice, and we have many patients that we've treated for multiple times before we gave up on PRRT with responses again. I mean, that's not standard, but we've done that. The alpha emitters are coming through, and they appear to be at least promising enough that they may actually be functional even post PRRT, or ultimately may replace PRRT. We don't know yet. I mean, these are questions that are being looked at. Now, at some point, we will need other therapies. So we have a number of them, depending whether they're pancreas or lung or carcinoids. Temozolomide primarily in peanut, but you could consider in lung nets. Cabozantinib, everolimus, sunitinib, we're not using anymore. I favor Cabozantinib as my next line. You can argue that it's probably as active than everolimus, so with a flip of a coin. But my preference has been on Cabozantinib, starting with 40 milligrams. Based on the cabinet data, looks pretty interesting, pretty impressive. That essentially the targeted pathway with Cabozantinib, VEGF, and others are actually very relevant to neuroendocrine tumors. And we knew that from the days of sunitinib, but Cabozantinib is less toxic overall. We know how to manage it better. So I favored actually using Cabozantinib after PRRT. Now, the only exception is when patients remain very symptomatic or are very symptomatic, I may consider CAPE-TEM, capecitabine temozolomide, because of the close to 50% response rate. Actually, in some studies even higher than that. So patients get some relief and some of that durable.